Hi, my name is Dr. Salil Khandwala, and I'm the medical director at Advanced Urogynecology of Michigan. Today, we shall be discussing the value of urodynamic testing. On our website at www.augm.org, you can see a lot of our educational seminars. So if you go to the website, go to the section of educational seminars, and there are a lot of educational videos that you can avail of. So let's see what's urodynamics. So let's talk first about the female pelvic anatomy. So this is the head end, this is the foot end, this is the front, and this is the back. So the bladder is up here, below that is the urethra. Then you have the vagina behind that, the uterus on top, and then the rectum at the back. So this is the classic orientation of the female pelvic organs. The kidneys filter the blood and produce the urine, which is then transported down by these two tubes called the ureters into the bladder. The urine then is stored in the bladder, and when the time is right, it opens up and the urethra relaxes and the urine comes out. So it's an interplay between the bladder and the urethra. During the filling phase, the urethra is tightly closed, and during the emptying phase, the bladder contracts and the urethra relaxes. So it's the opposite. When the bladder is relaxed, the urethra is tightly closed. When the bladder contracts, the urethra relaxes. And that is governed by the nervous system. Urinary incontinence is an essentially involuntary leakage of urine that happens beyond one's control. And there are different types. The most common types are stress urinary incontinence, which is essentially leakage of effort with coughing, laughing, straining, or lifting. Urgency incontinence is that gotta go feeling where you have that intense desire to go to the bathroom or the urgency, and before you can make it, urine is just running down. Mixed is a combination of these two. So stress incontinence, essentially, why does it happen? So the most common reason is this. The dotted line is where the bladder is at rest, and this line is where the urethra is at rest, the tube. When the patient strains, the bladder remains there, here and here. And so also is what's called the bladder neck, the junction between the bladder and the urethra, because it's supported by the fascial or the strong tissue of the pelvis. However, if the tissue has weakened, when she strains down, the bladder and the urethra tend to sag backwards, and when they sag backwards, it tends to open up this junction, funneling it and resulting in urinary leakage. And that is called stress urinary incontinence. The urgency leakage is that gotta go feeling where you have the desire to go and urine is coming out. That's typically seen in a child. As the bladder is getting filled up, so this is the bladder and this is the spinal cord right here. So as the bladder is getting filled up by these ureteric tubes, there's a signal that goes from the bladder to the spinal cord that says, I gotta go. But there's an immediate signal that comes back to the bladder that says, all right, go. And then the child then empties the bladder in the diaper. But as the child gets more and more mature, the brain takes over. So this is the brain, this is the spinal cord, and this is the bladder right here. So when the frontal part of the brain, the intelligent lobe, takes over, the child realizes, I need to go to this thing called the bathroom. That's where my parents go to urinate. That's what I need to do. They don't wear diapers, and nor should I. So this frontal lobe then inhibits or stops that reflex arc and controls it until the time is correct to go to the bathroom. That is normal. But something happens over time, and this reflex becomes either very strong or this brain control just becomes a few milliseconds slower, and boom, the bladder goes. And then when the bladder fills up, before you can control it, it's just coming out. That's the gotta go, or the overactive bladder problem. Another problem that's not very common is called the overflow incontinence, where the bladder keeps filling up, and there is what is called retention, where the patient is not emptying her bladder. Then when it fills up so much, the pressure head of fluid in the bladder forces the urethra open and there is leakage. So this type of leakage is not associated typically with any preceding urgency. So why do we do urodynamic testing? Well, it's an objective assessment, and we need that for many diagnoses. So let's take a simple examples. So here is a patient who complains of a headache. So she comes and says, you know what, doc, I've got a headache. I think my blood pressure is up. Put me on a blood pressure pill. No doctor is going to put her on a blood pressure pill unless and until he or she does and takes her blood pressure. So guess what happens? You take her blood pressure, she is doing good, blood pressure is fine, so you tell her, listen, it's not your blood pressure that's causing it, it's something else that's causing the headache. Same thing, when you think that you've lost weight but are not sure, how are you going to determine and exactly know about it is if you go on a weighing scale and measure your weight and say, yeah, hey, I thought I'd lost weight, but actually I have not. Or another patient who comes and says, I've got chest pain, and then you're worried. Does she have some cardiac event going on, some heart problem or something? So you get an EKG test done, you get a stress test done, and all that comes back totally normal. And when that comes back normal, you can say, it's not your heart. It could be maybe a pulled muscle in the chest that's causing this problem. So that is the value of doing an objective assessment, and so is urodynamic testing. So what is it? It's basically a pressure fluid recording of the bladder. So what we do is we put a tiny little transducer which records the pressure and also puts water into the bladder. So this little transducer measures the bladder pressure. This one measures the urethral pressure. Then we put a second pressure which goes, a transducer tubing that goes into the vagina, and that measures the belly pressure. So this allows us to measure the pressure in real time as the bladder is being filled up. So this is the water that is being put into the bladder by the urodynamicist, and then she's watching on the graphic recording to see what is happening as the bladder is being filled up. So we have a little special chair that we have the patient sit, and we fill the bladder up, and then we may have her stand and do some provocative tests. So we look at the bladder pressure, the belly pressure, the true bladder pressure, which is a subtraction of this from this, and then the urethral pressure. So it's done completely awake in the office. It does not require any anesthesia. It takes about an hour to do this. There is minimal discomfort after the test. You may get some pyridium to help with that. There's a very low risk of bladder infection, essentially no complications, and you can return to work immediately after the procedure. Now, before the procedure, we may just encourage you to come with a full bladder so that you can then empty your bladder in a recording and we can see how well you're emptying. So the urodynamics has a few parts. First is the filling phase when we are putting the water in. Then we assess what is the first sensation, what is the fullness amount, and what is the maximum that the patient can hold, and compare it to the normal amounts. Then we look at when does the urine leakage occur and why. Does it because of coughing? Is it because of this urgency problem? A combination of the two, or what else is going on? Finally, we look at how well she empties her bladder. Is the bladder contracting? Is she pushing? Is she straining? Are the muscles relaxing? And what is the mechanism of urination? So why should we do this urodynamic testing? Now, this is the very reason. 65% of patients with bothersome urine leakage do not return to the specialist doctor, someone like me, after one office visit. So it's not that the problem is gone, it's still there, but they do not come back. And you'll say, why? Well, more likely, there are many reasons, but one of the main reasons is that the treatment did not work and the problem is ongoing because the diagnosis was wrong. It so happens, and it was based upon patient's history. So a patient comes in, she sits across from the doctor and says, I've got this problem of urine leakage. And based upon the history, put her on a medication. She goes home, takes it, and says, what? I just got dry mouth. It did not help my complaints. The first doctor put me on a medication. The specialist doctor puts me on a medication. Forget about it. What do I do now but wear a pad? So that's why they don't go back. So it's so important to come up with the right diagnosis, because many a times what happens is that this particular diagnosis may not be correct and the history may be unreliable. And is it so? In over 50% of cases, the history is not reliable and points towards the wrong diagnosis. For example, when the patient says, I stand up and I feel urine leakage and I have to rush to the bathroom. So a history diagnosis, or rush to the bathroom, that means she's got this gotta go thing, or urgency leakage. So her history diagnosis, she has urgency leakage, but when we do the urodynamics, it turns out she has stress incontinence. Why? Because when she stands up and does a little bit of movement, she has a slight leakage, and then she feels, oh my God, it's coming out, and then she's running to the bathroom. But it was mainly induced by some stress or effort. On the other hand, if a patient says, when I'm running, my pad is completely soaked. Now, if you think, okay, if she's running, that's exertion. She's got to have stress incontinence. But when we do the testing and say, man, she doesn't leak at all. There was absolutely no urine coming out. We had a cough and standing and everything and nothing. At urodynamics, there's no leakage. Then you make a diagnosis of, right, she could be excessively sweating. So the filling phase is when we are filling the bladder up, and then we're looking at this tracing, and then let's see how we see. So as we are filling her up, here we have her cough, and that's called CLPP. These are little code words, and she coughs and she leaks. Another code word that says that when she's straining down, she's push, and she leaks. And again, we have a strain, and she leaks, and 3 times. So it's a consistent strain leakage. Then we continue to fill her, and then she says, I've got some urgency, and lo and behold, you can see the bladder. This is the bladder muscle, which is completely flat and happy and behaved, and then suddenly it takes off, and you can see a bladder contraction happening here, and that's associated with leak and leak. So she not only has stress incontinence, but she also has urgency incontinence, and which is then referred to as mixed incontinence. Then we look at, okay, we found out what happens. We know her starting amount, her fullness, her maximum capacity. We also know why she has a leakage. Now let us see how well she empties her bladder. So here you can see that we put in about, it looks like 289 cc's in her bladder, and she puts out 237, which is not bad, about 30, 40 cc remaining behind. Remember, she had urged and she had leaked a little bit on the way. But when she's emptying, she's straining. This is a belly pressure. The belly pressure is going up. The bladder really is not doing a whole lot. So it's like when someone goes to the bathroom and you're pushing to go to the bathroom. Well, you should not be doing that. So this is not the correct mechanism of urination. The correct mechanism is let the bladder do its thing. You don't have to strain. You just relax the pelvic floor, let the bladder contract, and the urine will come out. If you push, you don't want to do that, because then you're putting too much pressure, and then the bladder says, well, if you're going to push, I don't need to work, and we don't want that to happen. So the reasons why we do the urodynamic testing, especially when it's a mixed picture, is it stress or urge? Urge is more or stress is more, that'll help us also. Especially when it's going for a surgical correction, or it has failed a prior management, or the diagnosis is unclear. She just says that she's sitting and she feels urine leakage out, and then you're scratching her head and wondering why. Her exam is normal. Why would she just leak with urine just coming out when she's sitting and not straining? When patients have incomplete bladder emptying and we find that they have retention, then we want to know, why does she have retention and why is she not emptying? What is happening within? Or if she has a post-void dribble, that means after urination, when she stands up, a little bit more comes out. And she says, that's crazy, because every time I put my underwear back on and there's urine dribbling out. So we want to know what is happening. Is it a diverticulum? What's going on? So urodynamics gets us insight into the bladder. So that's very important. It helps us, especially when the history and exam is unclear. It gives us insight into the bladder. It gives us sort of like eyes in the bladder, because now we can see the pressure recording of the bladder and the urethra, like an EKG test gives us that information. It prevents us from making the wrong diagnosis, and it also helps the patient understand, because now when you look at it and you say, what I've got is got to go, and it comes out, and then you look on the paper and you see how the bladder contraction went up, then you say, oh, I understand why it happened. Potential risks like dysuria, you may have slight burning after the test because we use that tiny transducer. Very low risk of bladder infection. In some women who have pelvic pain already, they may notice a little bit more discomfort, but it's usually transient. Bottom line, urodynamics really helps correlate the patient's complaints. It allows us to provide the correct treatment without any guesswork. That's the key. There's no guessing. It's not you sitting across from me and I say, all right, that's what it looks like, take the pill. You have a headache, fine, take a blood pressure medication. No, you have a headache, let's check the blood pressure. You have these bladder complaints, let's check it and see why you have it before we put the treatment on. It helps the patient also understand the condition better and why it's happening. And it's, after all, an office procedure with very low risk of complications. Granted, you have to sit in the chair, it's not like a walk in the park, and you have to have those tubings. But let me tell you, the urodynamicists know exactly how to do it, and that information that we get is extremely, extremely helpful. And along with your history and the voiding diaries that I've already talked about in a different talk, it helps tremendously. Bottom line, why are you coming to see me? Because you want the correct treatment. To come to a correct treatment, I have to actually come to a proper and an accurate diagnosis. Once the diagnosis is correct, we know what we can do, and that is how we can swiftly manage the problem.